20% of them have excessive daytime sleepiness. So we do try to separate them. I'm not going to talk a lot about the fatigue related to Parkinson's, although as it ends up, it's often treated the same way as the excessive daytime sleepiness is. So this is just a nice little schematic of how the different, some of the different sleep disorders and other complaints all sort of come together to cause sleep disturbance. So I'm actually going to start down here with sleep apnea syndrome. So these are sort of some of the sleep disorders: sleep apnea, insomnia, REM behavior disorder, and restless legs. We're going to talk about each of those as we go along. There's a lot of different psychiatric complications as well that can occur here. There's a lot of disease-specific motor symptoms that affect your sleep. And then, as we're going to talk a little bit about, your dopaminergic therapy also affects your sleep quite a bit in both low and high doses. So all these together sort of create. And the key is trying to, the person who's, if you go to see somebody about this, they really got to take their time and ask about all of these. Okay, because it would be so easy to focus in on sleep apnea, which is the most common sleep disorder in sleep centers, and you could have it and treat it, but it may not fix you if you're also having problems with restless legs or insomnia or something like that. So again, these are the spectrum that I'm going to talk about: insomnia, excessive daytime sleepiness, sleep disorder, breathing, restless legs, and REM behavior disorder. So insomnia is generally divided into two types. Sleep onset insomnia means you can't fall asleep, and sleep maintenance insomnia means you can't stay asleep. Okay, you could have both, or you could have one or the other. Both are highly prevalent in patients with Parkinson's, but there are some surveys that indicate that sleep maintenance insomnia is the more common, meaning that you're going to be able to stay asleep okay, but you're going to wake up a lot during the nighttime. So this is similar to the slide I just showed you, but a couple of things I wanted to add to it. So we already talked about how psychiatric problems can affect your sleep, so they're up here. And of course, patients with advanced Parkinson's can develop dementia, and as we talked about before, dementia is a major cause of insomnia. Going to talk about these. So this is a big area right here. So the nocturnal motor problems. And actually, I helped write the board examination for sleep doctors, and we have a question on this on the boards. What to do with the Parkinson's patient who comes in complaining of a lot of stiffness at night, inability to turn over, what do you do? So this is, and we're going to talk about the answer to that is in a slide or two, but this is a common problem in Parkinson's. There can be neuropathic changes. Now, by this I mean not peripheral neuropathy, but central, meaning that there is some evidence that with Parkinson's that the wiring that helps promote sleep is actually not working as well. Okay, so the centers that should turn on are not, and the centers that should turn off are not, and so you end up being more alert. Then the dopaminergic agents are a big issue, and I think I have a separate slide. So sleep at onset insomnia is a common side effect of the dopaminergic agents, particularly large doses. Okay. The problem is you get to the large doses because of number 2 here, which is that sleep maintenance insomnia is often due to insufficient dopaminergic agents. Okay, so you're not getting enough dopaminergic agents, so you get stiff and have other nocturnal problems at night. So your doctor starts raising your doses, but then those higher doses could lead to insomnia, and so you end up having to balance it out. You know, which one is the more important one for the patient in terms of the one to treat. Now, in terms of treatment of insomnia, I read 3 or 4 different review articles in preparation for this talk, and they all came to the same conclusion, which is on the first 2 bullets there. There are no good randomized trials, and there's no clear guidelines. So there are multiple guideline sets for Parkinson's disease, And in the section for sleep disorders, there's really no good recommendations, okay? A lot of the medications, of which a couple I'm going to mention in the next couple slides, have been studied in one study with maybe 30 patients, okay? And so a lot of the treatment of insomnia has to be very individualized for the patient. It needs to start with a good sleep history and a very good history regarding your Parkinson's symptoms. The other thing to note about most of the research in this area, it's all based upon subjective parameters. Now, at some level, there's nothing wrong with subjective parameters because the patient's most important, okay? But sleep doctors love evidence that's harder than subjective, and that's doing a sleep study. So seeing that your sleep time gets longer, you have more stage 2 and less stage 1 sleep. That's what sleep doctors love when it comes to insomnia research. And we have very little of that in Parkinson's disease. So most of the things I've read about and what the answer is on the sleep board exam is that if there's significant nocturnal motor symptoms, you should start by either using a long-acting or sustained release formulation of your dopaminergic agent. Okay, and if you're already on one, consider at least going up a little bit on the dose to see if that would improve things. Okay. And again, with the caveat that the sleep onset insomnia could occur or worsen when you start going up on the doses of medication. For sleep onset insomnia, we usually start with sleep hygiene education. So we go back to those slides earlier about sleep hygiene and just really work with the patient, make sure they know all these things. They pertain to all disorders that associate with insomnia. So even Parkinson's disease, they're good for pretty much any disorder. After that, we could start doing what's called stimulus control therapy and sleep restriction therapy. So stimulus control therapy is related to that part I was telling you about not staying in bed too long awake, okay? So most insomniacs, when they come to us, have never heard that advice, okay? So they're in bed an hour, 2 hours trying to fall asleep at night, okay? And so therefore their bed is now a stimulus. So we're controlling the stimulus control therapy, by telling them you get into bed, you give it 15, 20 minutes. Now, some people don't like that because we don't like you watching the clock. So the other thing you could use is when you really start sort of getting antsy. I'm not falling asleep. It's usually about 15, 20 minutes. You get up out of bed, you go back, you can go back and read, you can go back and watch TV. When you feel sleepy again, you get back into bed and you repeat until you actually fall asleep. And again, it's slowly dissociating your bed from being a place of wakefulness. If that doesn't work, the other thing we do is sleep restriction therapy. So basically, we restrict the number of hours the patient is in bed. This ends up giving them a little bit of a sleep restriction and sleep debt. So over time, they get sleepier, and it promotes them being able to fall asleep when they actually get into bed at night. And then as their efficiency gets better, they sleep better in the time allotted, we can give them more time to sleep. There's been 2 drugs studied for insomnia specifically, but again, just really one study in each case. I can never pronounce this name. Iscoplicone, which goes by the trade name of Lunesta, and quetiapine, which goes by the trade name of Seroquel. Okay. Both of these studies, though, were primarily studied to see what they would do with alertness during the day. And the thought being that if it improved their sleep, they would improve their alertness. So they had outcomes for both alertness and for the subjective sleep, and both of them were associated with improved subjective sleep, particularly being able to fall asleep better. So one of those could be used. If I were to have my druthers, it would be the top one. There's less side effects. Seroquel has a decent number of side effects, but is a great drug when used correctly. Excessive daytime sleepiness, again, generally found 20-25% of patients with Parkinson's. At one time, it was more classically described as a sleep attack, meaning that you were wide awake and then sound asleep. Those appear to be much less frequent, probably only about 5% of patients with Parkinson's. Sleep attacks are considered a classic syndrome, a symptom of another sleep disorder called narcolepsy, and I have to admit I see that rarely. Most people are just sleepy all day long and fall asleep from time to time. So another nice little graphic of all the different things that can affect sleepiness in Parkinson's disease. So again, it could be a primary sleep disorder. So again, if you were to have sleep apnea or restless legs, which we're going to be getting to, those disorders in and of themselves can cause sleepiness. So it may not have anything to do with anything else on this slide. Concurrent medical conditions. So again, people with a lot of other chronic medical conditions tend to be sleepier during the daytime, and so those can be affecting you. There's again evidence that for some patients with Parkinson's disease, the wiring is not correct in the brain. So the centers that should be keeping you alert during the day are not working correctly and therefore contribute to being sleepy. Medications. So as it turns out, as much as I've been telling you that dopaminergic agents make you not fall asleep at night, there's also good evidence that they make you sleepy during the daytime. Okay? It depends on which study you read, how they're looking at it. You know, there's a lot of variables here, but you can read it both ways, that these agents, and for someone who treats restless legs, and restless leg syndrome is also treated with dopaminergic agents, if you go to Epocrates, which is the smartphone app that we all have, docs have for drugs, all of these agents list sleepiness and insomnia as a side effect, okay? And I see it both ways in these patients, and they're only taking it once a day at nighttime to help them with their restless legs. So it's a balancing game between you and your neurologist. Again, some of these others, if you get up a lot during the night, if you're dementia, not sleeping well, nightmares, all these sort of interplay with the excessive daytime sleepiness. Okay. Again, no clear recommendations as well as few well-designed studies. The drug that's been studied the most, 2 studies, okay, small numbers, is modafinil. It also goes by the trade name of Provigil. This is what most authorities would offer. Now, our modafinil or Nuvigil is the sister drug. This was Cephalon's way of getting around the patent issues. They just created a sister drug, and now they can make more money again. So either one of those could be used interchangeably. This drug is often also used for the fatigue in Parkinson's disease as well. And from what I can tell, there's even less evidence for that than there is for the excessive daytime sleepiness. But that is what's often used. And again, there are small studies for using quetiapine and Celagene, although Celagene is not a widely used drug because it itself, again, has a lot of different side effects that have to be carefully monitored for. So if you do have excessive sleepiness and it does not appear related to like sleep apnea or restless legs, modafinil would definitely be the agent to try. Now, sleep apnea is actually the most common thing that sleep doctors see in sleep disorders labs. But as it turns out, it's probably not necessarily more common in Parkinson's patients. But if you have this, it's relatively easily treated, and you should definitely have it looked into because we can hopefully make you feel a lot better. So this is a syndrome characterized by recurrent collapse of the upper airway during sleep. The collapse is associated with arousal from sleep and your drops in your oxygen levels. The prevalence in Parkinson's disease appears to be about 40%, but whether this is increased relative to the general population is not clear. Most people would now say it's not. The reason, though, why it's a common thing is that this, in general, sleep apnea is an obesity-related disease. And so since obesity is pretty common, no matter what other syndromes you might have, this is definitely a potential for a common problem. So basically what's